Okay. Okay. Good morning, everybody. I hope you all enjoying your lockdown period. Looks like the many things are happening with the profession as well as the. Am I audible? Am I audible? Okay, good. Okay, I think I need to come a little closer. Is better? All right. Uh, Perfect. Uh, this is just a initial bit lag. We are trying to adjust with the dental reach people. As you all know, I would like to speak a little bit about a dental reach. Um this is a platform. It has been built for us, in fact, by our own same group. Uh, this is where they're generally bringing in all the components of the learning part of the dentistry, which is really, really making a lot of sense. What was missing from the dentistry point of view is a platform where we can do the multiple activities ranging from webinars to lectures to interviews and the latest development that is happening in the dentistry and updation about that, and also kind of online a magazine. All put together, I feel that the Dental Reach has made a wonderful name, bringing in all together, especially from the very philanthropic approach and no vested interest anywhere. I wish them all the best, and what they are doing is a wonderful job, and it is going to help us a lot in long term. Apart from this, coming to today's topic, I've been uh, practicing dentist for last 20 years. This is my 21st year. Uh, Apart from this, I've been associated with academics. I was a research consultant, and I've been practicing endodontics for last 15, 16 years. And since I run my own academy and associated with a few of the Western universities, hence I get to see what is the latest thing. I get to work with some of the very uh, conceptual products before they come to the market. These are all puts me in a very niche position to see what is the change that we can expect in near future, and also what is the trends that have evolved, which is making sense. And sometimes it doesn't make sense, but it has come as an additional feature of the product. And now, putting the whole thing, speaking it in a very comprehensive manner, uh, what I would try to discuss today, and I would try to give out the some of the key information what every practitioner should know. Or else, most of the time we get carried away with either the beauty of the product or the marketing strategies or with offers and many things, forgetting what is exactly clinical relevance, and what is the feature which has still a feature but not yet evolved as a dependable, accountable strategy to perform the treatment. Considering all this thing, I have made a very comprehensive presentation to make sure every practitioner is aware of what he's buying, what he's using, what are the benefits, maximum benefits he can take it from that specific motors, whatever we are using. Classically, what we have seen is many of practitioners, they have bought the endomotors of a various types. Some are super expensive, some are like okay, some are are decent enough to perform. But let me put it very clearly: any endomotor can do a rotary endodontics. There is no doubt about it. I'm yet to come across a bad or the worst endomotors. All are doing decently well. But I have seen this classic pattern of practitioner buying it, using it for one or two cases, and then packed up and kept it back in the cupboard and never been opened for a very long time. And it's a kind of guilt trip. Now you have invested so much and you're not using it. There's one pattern. And the second pattern is like you feel that you are so accustomed to the hand instrument and so used to uh, your conventional method of treating it, and you feel that why not do that itself? Why go for a newer things? You can have some water, and that is the another challenge. Believe me when I say this. Roche Endo is a way superior, efficient, and predictable compared to our hand instruments. The success rate or the ability to clean and shape, predictability, they're all far superior than any hand instrumentation method can ever achieve. I have loads of reports I can share with you all. Apart from this, now there are too many things in the market, ranging from various price categories, and that comes with various offers. Now the question is, especially for beginners or early adapters, or even for the existing practitioner, the question is always like, what should I buy? Or should I buy one more with the existing endomotor, or should we be uh, discarding the old one? What is the sensible message or the factors we can depend upon to make a right decision? Let me walk you through the whole process of rotary endodontics and uh, what is the influence of endomotors over the performance, and also uh, how we can make a best decision uh, while performing or while using the rotary uh, endomotors in our practice. Let me go to my presentation now. Uh, Something is, do you see the first page? Can I see that? All right. There may be a little lag uh, from the things what I see here and what you people say there. By the way, this picture is, do you see the cursor moving? Okay, that those are the endomotors what I've been using it for last few years, and nearly six of them are missing because of a lockdown. We couldn't put everything together from the various clinics and other things. So as on today, I have used something like around almost like 21 different types of endo devices for the rotary endodontics, ranging from our Antho guide to the latest adaptive and Xmart IQ and whatever is there. All right. This is me. This is, I think I'm not audible. Okay, this is me. Just a second. Is it better now? Those are my credentials. So just to say that yes, I have a little knowledge to speak about the topic, and I have worked on, as I said, as an academic side, as a clinic side, as a research side, and also in association with the many universities. This is just to claim that yes, I have a little knowledge on this. As I said earlier, these are the endo-motors we have used, and also a few more are missing here. And this is our activities at University of Buffalo, where we do both implant as well as endodontic programs, microendodontic courses there. There's the University of Florida, and I'm not sure how far you can recognize. That is Dr. Haddix. That's me, by the way, who has written the chapter about access cavities in Ingalls, and Dr. Umar Nair, latest edition, those who have seen CBCT in endodontics, Cohen 10th and 11th, sorry, 11th and 12th edition. She is the author of that, and also Dr. Azim, Abdul Azim, who's a very authentic research guy. He's written many chapters on rubber dam and surgical endodontics. Um, these are all the activities at the different universities. Dr. Naiva, Dr. Pelagi, who gave the concept of why we are not supposed to do the pulp testing, a vitality test just after the trauma. And Dr. Naiva is exclusively working on revascularization. Why should we obturate? Why can't we re-establish a pulp-like structure within the tooth? And this is a center in Bangalore. And these are just our activities, what we do. Coming back to the endodontics from the clinical perspective. Before I get into the rotary, one should have a clear perspective towards where exactly the rotary fits in and how do we see this. In 1965, I'm not going too much into the theoretical part. This is just a preamble one needs to know to understand the role of rotary endodontics in dentistry. In 1965, the first study came saying that onoticate is a bacteria which is causing the periapical problems or a dental infection, whatever from the endodontic perspective. Okay. Then we learned two things from there. One is like if infection is causing the problem, that means that if I remove the infection, everything should be fine. So goal of endodontic treatment became if an infection is effectively under control, the tissue should be able to heal. Here, the key word is effectively under control. We didn't say complete elimination of infection. We just need to control to a very large extent where our immune system takes over and maintains the healing as well as the health of the tissue. So hence, we had two things in mind while doing this endodontic therapy. One is a biological objective, that is like the tooth was all right, the bacteria, the microorganisms went in and caused this problem. Okay, and our primary target is to get rid of that microorganism, whichever was causing, along with any tissue that may provide an environment for this bacterial growth. Crystal clear. We wanted to just get rid of whatever has been, whatever had been causing the problem within the root canal. The second aspect is to achieve the biological objective, we needed the tools and we needed to prepare the cavity for the two purpose. One is like cleaning and getting rid of all the unwanted microorganisms, and also prepare the cavity in such a way that it becomes easy for us to seal it. Like, for example, when I cut the class 1 cavity, my primary objective was to remove the caries and also make a cavity preparation in such a way that it becomes optimal or perfect in shape to receive the restorative material. So the mechanical objective is two. One is to facilitate. or augment the cleaning mechanism. When I say cleaning, it purely goes towards the irrigation. When I say a canal preparation, it purely comes to the mechanical aspect of preparing for the obturation so that we can seal it permanently. So we have been using a various different terminologies for this purpose. Initially, we said biomechanical preparation. Then we simplified it and said cleaning and shaping, which was like a very laymanish terminologies. Then we went ahead and we termed it as a chemomechanical preparation. I personally feel this is a perfect terminology or a job run for the activity what we do, for the treatment what we do. All right. Now, the modern endodontics believes in five principles. Obviously, the whole area should be, the whole treatment should be performed in a very, very aseptic area, sterile area, and make sure that you clean the canal thoroughly by means of a mechanical and chemical agents. Shape the canals to obturate. The shaping purely comes towards obturation, and now we are not talking about a microorganism. And when we say cleaning, we are purely talking about microorganisms, not really the obturation. So, from that context, the second point is more towards the sterilization, disinfection. The third point is shaping towards the sealing. And the fourth point is obturation, so that uh, the empty canal may again become a hotspot for the any bacteria to come and recolonize. And since there is no vascularity, that might continue to provide a infection to the periapical area. And the final objective of our modern endodontics is to coronal seal. This is the one of the key factor in achieving the long-term success. Now, this is where the rotary endodontics actually comes. While shaping and while preparing the canal, we used to do either mechanically or with the hand instruments, and then with a partial hand instruments and rotary instruments like your gates and hand instruments. And then now we, with the invention of night eye and its adaptation and its improvisation at a metallurgical and a design and performance levels, we have really evolved to address the complications of the canal. All right. Now, how did this? Let's not lose the perspective. We are here. We are completely speaking about this aspect, shaping of the root canal with the rotary devices. Now, to reach that point, it wasn't that easy. Initially, we started with the mechanical, the hand instruments, and then a machine-driven, and now we have a software-driven. Perfect algorithms have been made to match the, the desired performance within the canal. If you ask me, for ages we kept doing the endodontics without a rotary devices. If you go back in 1965, we got the theory. 1954, 55, 53, 54, we got the standardization by the England Levine, and then henceforth, after that, we had a step back, crown down, double flare, hybrid. So many techniques were there, and so many instrumentation methods were there, and we were doing a decently a good job. The success rate was somewhere around 89%, which is fair enough considering the very rudimentary instruments what we had. But we had certain issues which we never wanted to acknowledge, though we were facing on daily basis. Hand instrumentation is highly technique sensitive, and second thing is it had a propensity towards pushing the debris beyond apex, and this is really beyond the human ability to perform, to limit, or to make an efficient execution of a treatment at every single case for every single canal on every single day. Imagine like Monday first case, you do the hand instrumentation technique using a K file, step crown down, step back, whatever. And Friday last case, that may be your 10th case or a 15th case or a 50th case. Same operator, same instrument, same almost like the same anatomy, but still your performance may be not as accurate as it was for a certain cases. If that is the thing, how can we standardize the treatment? How can we ever commit to the patient saying that one, okay, this is a predictable and this is consistent and this has got a better prognosis? These were the limitations. On a lighter note, we were using all these methods of techniques of performing the root canal using a hand instruments. Imagine like if you are doing 10 RCTs per day, sorry, even if I keep it in a lower end, 10 RCTs every week, 50 RCTs, 40, 50 RCTs every month, and if you practice it for 10 years, probably you would have developed a muscle like this. Uh, this is like your performance comes down with the age, comes down with the fatigue, comes down with the various patient, clinical, and operators levels. Hence, we needed a system where we had to avoid this human bias as much as possible. Why rotary endodontics? Now we're in a perfect mindset to understand the need for the rotary endodontics. Roxanne, if you go for the poll at this point, this poll is basically for you to see what is the your belief in rotary endodontics. Most of the time, when I go for a lecture or a guest speaker or hands-on courses, I keep asking the question, what do you think is the greatest benefit with the rotary endodontics? And most of the time, the answer was almost like the time or the patient comfort and the operator's comfort and all those things. I would say yes, that is correct, but that is a second factor. The first factor was with the rotary endodontics, we really solved two important things. One is predictability. Whether you are an experienced doctor or an inexperienced fresher or a person with a great knowledge or a person with a very minimal knowledge, your once you use a rotary endodontics with the fixed speed and torque and a specific tip and taper, your performance is going to be uniform across various operators. Don't you think that, that itself is a big achievement? That means that when the canal is prepared to 25 6%, whether that has been prepared, whichever the operator, but your outcome would be same. Good or bad, but outcome would be perfectly same. Of course, the time factor. We can reduce the time, but this reduction in the time factor should not be seen uh, from the uh, reducing the overall treatment perspective. Of course, the single visit was possible, and we could do it because of the rotary endodontics. But here, when I say the time is reduced to prepare the canal, I'm speaking about only the mechanical aspect of the canal preparation. The rest of the procedure remains exactly as it is. In fact, I see it from the different perspective. When I reduce the uh, amount of time required for the canal preparation, I would spend more time on the irrigation of the canal. I can perfectly go for the full protocol of the irrigation and get the perfect disinfected, sterile cavity, which is ready for the uh, obturation. Of course, whether you do it one case, 10 case, your stress on the operator is reduced, enhanced debridement because the rotary, the helical blades are continuously augering the debris towards the coronal side. And of course, human bias is avoided. Why do we like to know anything about uh, rotary endodontics? Why can't we just buy it from the market and start using it? It is exactly like saying, why should I know anything about dental cement? Why can't I just buy it from the market and start mixing it in and using it? No, we didn't do it. And that's not the professional way of doing anything. We need to know uh, the details about the equipment or instrument so that we can take a full benefit of that. When I say full benefit, that comes with the limitations of that particular method. Here, once you know what your endomotor can do, what it cannot do, what are the limitations, and what are the newer advantages that has been incorporated, you will be in a better position to use them. You will be in a better position to take a full benefit of that feature and give the best for the patient. All right. Now, this is where we are all stuck. When any profession evolves in a very small period of time, we may think that endodontics has been there for a long time, and there must be one of the oldest profession. I'm sorry to say, my friends, in 1963 we had a implant in the human mouth, and 1965 Takahashi was still looking for the reason for a scientific reason for endodontic infection. So ours is very recently evolving. It's been there, but it is recently evolving profession. Only in 1990 we started seeing the use of NITA in endodontics. In fact, you all should know, first time the nickel titanium was used in for the root canal purpose by an Indian, Dr. Harmeet Walia, an ex University of Florida a graduate. Uh, I happened to learn from his contemporary, Dr. Haddix. So this is like, only post 90s the profession started evolving. Because of that, what happened? Many companies, since there's such a great demand for, or such a great uh, 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 requisite for the newer and evolved methods, and now so many products have been introduced to the market without any scientific basis. Hence, I feel this topic should give you a little edge over the marketing knowledge, whatever the people can throw you upon, and then you should be able to make a better decision over that. Now, coming back to how did exactly Rotary evolve? By knowing this, you will exactly know where do we stand as an today. Uh, Somewhere in the early 60s, we had this oscillation. They are more or less like a mechanical devices. And in fact, the first a rotary, to claim it as a rotary, 1912, we had a first rotary instrument. 1925 also, there was some improvements at a reciprocation and oscillation level. But we have a solid evidence that in 1964 we had an instrument, Endo-motor, which can use our hand instrument, and it can oscillate uh, in both 90-degree clockwise, counterclockwise. And 1992, we have rotary and then reciprocation, the axial movement and the rotary eccentric movements, and the latest what we have is the adaptive motion. Okay, this is how it has evolved. Now let's go in detail, like how exactly things have evolved. On a very vague scale, as a simple way of understanding, we used to do a digital or a finger or a mechanical method of preparing the canal, and then came the rotary, and then the reciprocative type of instrument motion, and then adaptive. We'll go one by one in a little more a detailed manner. I would say this is all the five varieties we have in the market now. We have a rotaries and a varieties of them. Eccentric rotary motions, we have a XP and a pro next type of a thing. Here we see the swaggering motion, and you must have seen the XP 3D shapers. They look more like a spring. Um, this is more at a instrument level, and a high speed endodontics is seen at eccentric rotary motion. A reciprocative, we have a wave one and reciprocal instruments. Here the device, the Endo-motor, should have this feature. When we say eccentric rotary, especially from the XP 3D shaper perspective, we need to have a motor which delivers the speed of around 1000 plus rotations per minute. When I say rotary, I'm specific towards the any speed somewhere between 150 to 600 range. Typically, we work somewhere between 250 to 350 rotations per minute. Then came the transaxial motion, which made a huge impact, and initially it was a big celebration for this instrument. But gradually we realized that this is more of a activation method rather than the preparation itself. There are several studies compared the transaxial motion with the other methods of irrigation activation. The results were almost similar, but still very interesting product we had witnessed at one point. Then the latest what we have is an adaptive technique introduced by Cygron. Here, any instrument can be used. Here, we made use of a best of the rotary, best of the reciprocative motion, and we put them together, and your software stitch these two performance seamlessly, so that you are just using the instrument, and the equipment will decide whether should it go for rotary or reciprocative all by itself. So we'll go one by one. Now let's see the rotary. Initially, our demand was more or less towards the uh, we wanted a reduced speed and enhanced a torque. So there were no Endo-motors invented at that point. And then we had to make use of a gear reduction handpieces. We had a 1 is to 72, 1 is to 20, and anthogyr, and a gear reduction system. So many things were there. And then we could classify them according to the evolution, what happened. So it was basically a torque control, then a speed and the torque control. When I say speed and torque control, second generation, these were the fixed torque. And then we had a third generation where the speed and torque can be separately controlled. And the fourth generation, we had apart from the speed torque, we had an integrated Epics locator. Okay, now as a clinician, I'm not much keen on the classification and how the things evolve. This is basically, to acknowledge how the whole profession went through. What are the basic things an endomotor should have, and we all should know? Let me now get into the actual understanding of uh, the endomotors, whatever. A simple endomotor should look something like this. Excuse me. It will give you the speed controls, torque control, and also gear which handpiece has been used, and also a beautiful feature of auto reverse forward button. Let's see one by one. Especially this is for the people who have never used the rotary before, and they are the first timers, or they bought it and they have not really understood how to use it. I'm coming to those guys. Okay, our endomotor starts from here. These are the basic features, and this is a beautiful additional feature that has been added because your endomotor doesn't have a brain, and it has to be pre-fed about how it should perform when it is unable to cut the dent in at a specific torque. Let's see one by one. When I say speed, this is what I'm talking about. The speed from the perspective of like how many times a blade can come in contact with a specific part of the dentin. So enhanced speed has always resulted in two things. One is like with a conventional night eye, enhanced speed means okay, a deviation from the original preparation, and there may be a transportation. Okay, can we go for a lower speed? No, that leads to self-threading and other issues according to studies. Of course, this few manufacturers have managed this by changing the helical angle uh, at a different level, so that would reduce it. But still, the lower speeds less than 250 is not really advisable as on today. Higher speed leads to a cyclic fatigue. Continuously, the instrument might get stressed out and may cause a, a breakage. Uh, so, as on today, we say that around 300 to 450 should be a easy speed or comfortable speed to perform the rotary endodontics. When I say this one, this is not a blanket statement. This is for the specific category of the instrument. Of course, we have wide range of instruments. Let us see what is an influence of this on the performance. I'm sorry for the not so good video. Yesterday night I was trying to make some videos. When I say rotary, this is all it is. It goes in a clockwise rotation. With the lower speed, we have a good tactile perception of the canal, enhanced a cyclic fatigue if we increase the speed. Strip perforation might happen if I increase the speed, or it might cause some kind of a transportation. So hence we limit our performance within the 300 to 450 range of a speed. So if I go with a higher speed, you can see the way the motor is rotating. And if I go for a lower speed, like a 120, so that becomes a very slow, and the performance becomes uh, very delayed. All right. What is torque? A torque is, it feels like, it's very simple to understand from the endodontic perspective. You need to have a little more clarity on this. Torque is basically how much of pressure you're going to apply to the each rotation. So you technically see this, it is like how much of pressure being applied to make the uh, endodontic file to cut the dentin. Okay. Higher torque will always land up in a better performance. Here is a torque setting. When we keep it for a lower torque, that's the least any motor can take. Now I'll show you what happens when we work with a very low torque. I've set the speed for 300, and speed remains same, but the amount of energy required to chip or break the dentin is reduced. And when we use it, we observe the motor, it just stops it, and it is unable to cut, and it is unable to rotate. So from that angle, if I increase the torque, you can go up to 2.5 to 3 newtons, but I would always prefer to work between 1.2 to 1.8 range. The speed remains same. By enhancing the torque, now you can see the motor can perform better. By sometimes that, since I'm working at a dry canal level, uh, it is not really giving, but with the irrigation and the lubrication, it should work better. I'm sorry for the light. Now I have enhanced the torque to 3.5 newtons per centimeter, but now you can make out it can cut better, but at the same time it has got a very high potential for instrument separation. So higher torque is not really recommended. Lower torque may not be able to cut the dentin, so your comfort levels are somewhere between 1.2 to 1.8 newtons. And if that is not really giving you the desired uh, cutting, probably step by step you can increase the torque levels. Otherwise, directly starting at a higher torque, I don't personally recommend that at all. All right, now uh, let's see with the higher torque what is going to happen. This is to basically, I hope you all can see that. Higher torque, if the instrument tip gets binded, this would look something like this. If the tip is rotating and the tip gets locked, and you can make out, immediately the tip is broken, because all the torque is been delivered here. Now, if the tip gets binded, the instrument gets separated. You can see the small piece here. This is what can happen. So higher torque is not good. Gear reduction. Nowadays the new motors you don't really see this option, but the initially we used to have this gear option. This should match the motor, sorry, the handpiece, whatever you're using. If this says 16 is to 1 and if this says 4 is to 1, then there's a mismatch, and probably the speed and the torque, whatever your motor is trying to deliver, and your sorry, your uh, device is setting, and your motor may not be able to deliver it through the handpiece. Hence, make sure that these two always match. Sometimes the option was given for the purpose of where we could change the gear and also change the handpiece like a M4, and we had other reciprocatory handpieces and all those. And nowadays, like this is not the norm, and this is not something you should be really bothered about. Now, this is a beautiful feature of any Endo-motor, and it should have it. And if it doesn't, that means that okay, I don't think any Endo-motor comes without the auto reverse and forward feature. What really happens here is, okay, let's take a step back and understand. When we are using a rotary, when we set the speed for, as I mentioned, around 300 rotations, and a torque of around 1.2 to 1.8, and when we are performing the root canal, if the instrument is unable to cut or chip the dentin from the root canal, what should it do? Should it just stop and get jammed in the canal, or should it just unwind itself? Or what is that instruction we need to give? That is what has been added to this particular feature. Now let's see what really the auto reverse feature and how exactly it works. Now I'm going to use this. That is a feature, and when you press that button, auto reverse, there may be a different way it is mentioned in a different instrument. When you press the first time, you see a box with a symbol, and then press the second time, you see a border around that. Now let me turn it off to show you what really happens while using at specific speed and torque. Point 0.6 is not the torque advisable. This is just for you to show how exactly this works. I have set it for a lower torque. So when I use it for a lower torque without auto reverse feature, when it is unable to cut the dent, and it just stops. And this becomes a kind of a nuisance on the clinical side. How exactly I do remove it? Now the instrument is stuck. Now let me press this button again. Now there's an auto reverse feature, and see what happens. Now let me do it again. Before it stopped, it unwinds itself. At least like it becomes a little easy for you to take out the instrument. Now if I press the auto reverse button again, there's a box, and the feature of that is whenever the instrument is unable to cut, it goes counterclockwise. And when the pressure is relieved, you can make out forward, then suddenly it goes to reverse. And that feature is added so that whenever the instrument is unable to cut the dentin, it will inform you by going auto reverse manner. See this? It goes forward and then reverse direction. That is an indication that okay, the instrument is going to the full threshold. It is applying the torque to the fullest, and it is unable to cut the dentin. In any such conditions, what we need to do is we need to clean, we need to irrigate and lubricate, and then continue with our instrumentation. So we have just learned what is the speed, what is the torque, and what is the benefit of this auto reverse. When the instrument is continuously going in a reverse mode, you're not supposed to use that continuously, because it starts pushing the debris into the canal. The moment it takes a reverse rotation or a counterclock rotation, that is when take it out, either increase the torque, and if you're already at the highest torque level, probably you would want to uh, irrigate and clean the canal, and then use a lesser tip and taper instrument to continue the treatment. We have so many Endo-motors from this perspective. Uh, Now, latest Endo-motors are like there's so many things incorporated into that. Sometimes I feel that probably this is on a lighter note. It feels like all that I need to do is like buy this motor, keep it in front of a patient. Probably it will do all by itself. Uh, Jokes apart, but the features are so many. It gives you the impression that as if it can do all by itself. But we need to know one thing: it is the operator's responsibility to make these things work for you. A simple rotary motion would look something like this. I have done it. I have reduced the uh, I have captured this at a 10 times slower speed. So rotary devices, basically it's a clockwise rotation. Here you see the anti-clockwise because I'm holding the camera in a different angle. This is what the rotary device does. So your rotary motors are fundamentally, or essentially, this is like a clockwise rotation ranging between 250 to 500 rotation. And we have a basic motors with the cord, without a cord. Now if you are confused between should we buy the one with the cord, one without a cord, I will discuss a little bit about as we go further. Then we have integrated endo-motors of various companies. Let me make one thing clear here. I'm not giving a review about each product. I'm not discussing about like what are the products and what are the features and what is best, what is good. I'm basically trying to give you what are the features in most of the endo-motors and how that is useful on a clinical side. So we have the endo-motors where we have either they're connected through a cable or we have a connection through a Bluetooth, and apex locators are incorporated. They can simultaneously detect the features. Now we'll see one by one. Uh, More or less, when we have an integrated apex locator endomotors, you need a connection, a cable with a lip clip, and this would additionally give you the features like auto start, auto stop. You don't have to even activate the motor. It recognizes the thing. Not so predictable in every case, but this is something very exciting. Those who are using it very first time. All right. Then we have an endomotors with a built-in apex locators, which can be simultaneously used as an apex locator and also endomotor, and also sometimes both the features integrated. Uh, Sometimes we have a different unit, apex locator and endomotor connected via Bluetooth or a cable. Then we have a JMorita, one of the world's best product and most studied product. Then we have the latest things which are quite affordable for an Indian market, where we have a foot control connected to your a motor by Bluetooth, and your ender motor is also connected to the apex locator. So there are no cables here as such. Now, to understand the different types of rotations, we'll go one by one. We just saw what is rotary, how exactly it works, and what are the torque, speed, and auto reverse button. Now we'll see this eccentric rotary motions, what exactly meant by that by the endodontic as a thing. This is a rotary, this is an eccentric uh, rotary file. This is the difference. We always claim that our canals are not round in nature. When we use this eccentric rotary motors, they touch the various uh, walls of the different canals, and they can also be used for our regular round, oval. All right. So here is an interesting thing. See the way the instrument wiggles and clears the debris from all parts of the canal. So those are the eccentric, but here the speeds required are 800 to 1000. I have been also told that at a very research level they have used it up to 3000 rotations. But when we use a rotary uh, on the coaxial plane, here we can expect the canal to be highly centric, and while working with the oval shape of the canal, we may have some issues with the rotary devices. Okay, that's the difference. That's the eccentric rotary motion. Then we'll see the reciprocative instrument. What exactly meant by that, and how exactly those devices work. On a high level, we can understand them uh, at two levels. A true reciprocating is you should have an oscillation on either side at equal amplitude. If you go to 30 degree, you have to go 30-degree counterclockwise, 90-degree clockwise, and counterclock also 90 degree. But that led to a lot of complications. So more or less, this is what we use it: either forward 150 and backward 30, or backward 150 and forward 130. So we have this forward reciprocating and backward reciprocating devices. One of the classic motor here we see is early motors. What we had was Endo-motors, where we had a rotary, a reciprocating both forward and backward uh, cutting mechanism. So in a slow speed, how do they look? This is how it is: forward 150, backward 30, forward 130, 150, and backward 130. This is like a backward 150 and forward 30. So yeah, well, wave one is something like this. The you need to have, you cannot use all the rotary instruments in these motors. You need to have a file designed for a reciprocative movement. It's a reciprocative motion, and it is not really possible otherwise with the regular rotary devices. So you need to be very clear. If you want to use a reciprocative motion, try not to use it uh, with a conventional rotary files. You need to have a separate instrument like a reciproc, and you have a wave one, and we have many other things in the market. All right. Then we have XMart Plus, which gives you both reciprocating as well as a continuous rotary. One of the good product, and very sleek, very handy. Comes with a cable, and you can expect a torque range somewhere between zero point 0.6 to 4 Newton per square centimeter. uh, the speed range is up to 1200. Whenever I see the speeds above 800, for me that is a bit interesting, because the newer uh, the next generation rotary devices are going more towards a high speed endodontics. So hence I feel this is, it makes a lot of sense to have a little higher speed range. Then we have an XMart IQ. I was one of the early adapters. I've been using it for almost like 4 years, maybe now. And this is a beautiful device where you have an endomotor, very sturdy one, with a Bluetooth connection to your iPad mini. You need to buy a separate iPad mini for this. And of course, you have a cordless Apex locator as well. Now, the beauty of this is all these things are so seamlessly integrated. The moment you turn the motor on, the Bluetooth gets connected to your iPad. They'll give you an app. It is EndoIQ app. And in that app, there are already preset speed, torque, and all the features required for a specific rotary instrument. So you can pick and choose what you want to, which system you want to use it. You can record the treatment duration and the performance as per the patient, as per the tooth, whichever you're treating. And you can also track down the amount of torque and the peak of torque that has been delivered uh, uh, for that particular instrument. That gives you an additional benefit of, you will know the amount of stress that is being applied on that particular instrument. It becomes a little easy for you to discard that instrument. Or when there is an instrument separation, you can go back and check the instrument performance and its graphs to see what is your pattern of breaking the instrument. Around 1.4 lakhs, 1.3 or 1.4 lakhs range. One of the great product, which is a software driven. You don't have to make any changes to the motor, no buttons at all, and everything is like your iPad. You can make your own sequence to have your own set of files. That, in fact, like, you can make a sequence in such a way that you can use a multiple systems, and you can make your own sequence. Now let's see the very interesting transaxial motion. Uh, that is our self-adjusting files. I picked up one video from the YouTube. Uh, Here, the interesting thing is the design. It does the vertical reciprocating motion, and the whole file. You need to prepare the canal, if I'm not wrong, at least like a 20 or 25 4%, and then only you can use it. So there is always an rotary part, and then you can use this device or instrument to cleanse the canal. So don't be under the impression that this can be directly used in the canal to perform it. That may not be the case. With the reciprocating and anything with the vertical motion, we had this problem, apical extrusion. So you did a beautiful RCT, beautiful cleaning and shaping, X-ray looked perfect, working length was perfect, and patient came back with a severe tenderness and pain. That was because of the most of the time extrusion of debris beyond the periapical, uh, beyond the minor constriction. Here, what happens is the micro abscess, what develops, and irritation at the periapical zone. Your X-ray may not be able to detect this because this content is more or less, organic in nature and debris. And since there is not much of inorganic component, your X-ray may not be able to show up on the film or on the sensor. Now, what happens? The patient has to suffer a lot, and we were not really happy with this thing. So, consistently, there was a experiment conducted to see the extrusion ability of a rotary and a reciprocation methods when we used it in a canal. This one is like when we use a reciprocating instrument, as we go periapically, we can observe the amount of debris that gets extruded beyond apex. Are you able to see the video? And mind you, this will not be able to see this on the X-ray. So obviously, you have done the cleaning, shaping, but patient will land up in a severe tenderness and post-operative pain. Whereas a rotary, you can make out the extrusion has been reduced. I don't say absolutely no extrusion. There will be some amount of extrusion because of our picking motion, but uh, otherwise, compared to reciprocating moment, the extrusion of debris beyond apex has been reduced to a very large extent. So you can conclude two things here. When I use a reciprocating devices, there is a possibility that I might push the debris. Or when I use a rotary devices, these are the studies to prove that one, like how the reciprocating instruments significantly push more debris compared to rotary. But when I keep using only the rotary devices, there is a high possibility that, like I might cause a strip perforation if I use a conventional night eye, or there's a possibility that, you know, uh, in a complex canals, which is not of a round in shape, we may have a partially prepared canal. So we can say that should we go for a rotary or a reciprocation? Here is a beautiful article. I just found it by this is written by John West. By the way, who's this Dr. John West? John West is he's a co-inventor of ProTaper and Wave One. This is what he concludes. It very interesting. Uh, he says this is like he's a co-inventor of ProTaper and Wave One, and that means that the rotary and reciprocating devices. He says how to choose, your own testing will reveal. That means that you have to use it, and then you should know what is good for you. And he also puts it in a very beautiful manner. The results, the clinical confidence, the consistency, and the control, the marketplace has actually already answered the question, that is like you you have to have the feature of both rotary and reciprocation, not just a one type of a thing. And another interesting feature what I see is like the clinical confidence, consistency, and control. Believe me, these are like according to me, they are very, very vague, subjective terminologies. Each person's clinical confidence, consistency, and control is how do we evaluate that? And a rotary and reciprocation. So he clearly advises that a motor should have both the features. So keeping this as a background, and if we go to the next part, we had a limitations with the rotary. Eccentric motions were good, but they are at a very high speed. And reciprocative, we had a problem of apical extrusion. Transaxial, only one specific of rotary, not even rotary, your oscillating motors can be used. That is quite expensive, and again, the rotary is a part of this overall procedure. Now we'll see the adaptive, which is the latest method of repairing the canal. Why adaptive? As I said, now let's take the best of the rotary, best of the reciprocating uh, devices and put them together and see how it performs. The limitation of the rotary is a continuous rotary motion. So here that has been addressed by keeping a small pause after a 600-degree rotation. At the same time, and we have another feature. The motor seamlessly goes to a reciprocating pattern the moment it encounters the highest resistance. Let us see this. How does the adaptive motion works? When it is continuously rotating, it's not a continuous rotation. There is a 600-degree rotation and a small pause. And when it encounters a higher resistance, it goes for 370, 50. This is working at a 10x slow motion. You can make out that reverse reciprocating action is to prevent the instrument separation and apical debris extrusion. Since it is amplitude was only 50 degrees compared to 370, so very greatly we can reduce the apical extrusion of debris. So the results are this. Like we can see a well prepared canal, and gradually the cementum coming back, and the periodontal ligament growing back with the prepared around the prepared canal. So uh, the features what we get is like it is like 270 207% better than our hand instruments, of course, obviously. Uh, Apical extrusion is reduced. I personally like the feature is it gives you the speeds of up to 3,000 rotations. So we can also use this like a surgical handpiece. We can also this is like a future proof because like as I said, now the endo is going more towards the high speed endodontics and next generation A phase alloys, whatever is coming into the market, they all will be working at 1,000 plus rotations. This is just to show how exactly clinically we can evaluate this. Make sure your chamber is completely filled with the irrigants. Instruments are coated. You can make out the motion of the tooth itself is an indication that now how the rotary works. Let me use a little larger size just to show you how the whole thing works. I'm using a 35 4%. So it goes for rotary as well as a reciprocation all by itself. I don't have to make any changes. Now the rotary and then reciprocation as per the need. So you just have to set the motor for adaptive motion. Now let's speak about the high-speed endodontics. What is that? The next generation endodontics is going to see, or how we are transforming from low-speed to high-speed endodontics. Here, just to show you the the performance, I have made a small video in case if you have to prepare the oval shape canal at a higher speed. They're safer; they don't get separated that easily. But it touches all the walls of the different shape canals, so that your performance is are better. The tooth to instrument contact point would be much higher compared to single coaxial rotary devices. Yeah, this is generally a 34% instrument, and after the preparation of the canal, we have to go with the 34% or higher sizes, depending on how long you have used the instrument in the canal. Let me show you how the high-speed aeronautics works for a RCT. It's a beautiful. I have set the speed to 2000. So within no time, you can get the GP out. Irrespective of whatever the method you have used for obturation, thermoplastic, a single cone, or lateral compaction, the device takes out the GP. And if you notice, I have not used any solvent. All right. Clinical guidelines. We have understood the rotary, we have understood the reciprocating, we have understood the coaxial upline cutting, and we have understood the adaptive motions. Now, what are the little clinical guidelines one should follow while doing the rotary endodontics? First, and the very important thing is the straight line access. Uh, you might get influenced by seeing the social media, some of the cases. Okay, to achieve that level, you need a little expertise. So till that point, make sure that you have a straight line access and that goes straight into the canal without any coronal hindrance. And second thing is never leave this pulp ponds unattended, because eventually the debris from there will start softening the dentin around that, because the ingredients will eventually go into the submolecular level, and that becomes a low pH area and start softening the dentin. Not a caries and infection; it has got other influence also. So straight line access is to make sure that you have a perfect entry into the canal without any premature contact on the coronal side. Because if your instrument is made to cut the dentin, not the enamel, so make sure use a Digi16 to locate the canal and see the orientation and evaluate any hidden pulp ponds or any chambered uh, ledges. All right. You should be very familiar with the anatomy. You should know the six laws of canal location, and that will really save a lot of time, especially when you have a calcified canal. So when you have uh, you know a various different configuration, where to look for the canal, where to search for the canal. Any textbook will help you with this. We have a beautiful six laws of canal location that can be utilized. You should be very familiar with each tooth and its uh, dynamic changes with the time and the age, chronological influences, and various other things. Always use a Digi16 to locate the canal. The moment you start seeing the bleeding in the chamber, don't put your endodontic instrument into the canal. That is wrong. You will do more harm than any good. So make sure you always find the locate the canal using a Digi16. Make it a pattern. Make it your protocol. Establish your working length Here, you need to use uh, either 8 or 10 size K file to identify the working length, and always try and establish a 00 reading, because that is where almost all apex locators are very efficient. When they say half a millimeter short, 0.3 millimeter short, and all those things, when we test many apex locators, they may not be very accurate. Some of them are not very accurate. So don't take a chance. Always try to get the 00 reading and then subtract whatever you want to do it from there. And exploratory glide path are key for your success. You should know the how to scout the instrument, coat the instrument with any EDTA gel. I personally prefer using a 10 size K file. Uh, if I'm using it for a posterior, use the short length, that is 21 millimeter. And this is after taking out all the chamber content. The scouting is basically counterclock and clockwise motion, and never rotate the instrument till you get the desired depth. Here what happens is, like, if you force the instrument, if you twist the instrument, and if you push the instrument, you will end up having either ledge or instrument separation or extrusion of infected debris. So make sure that you do the exploratory glide path. This gives you a tactile sense of like what is the canal you're dealing with, and it prevents the instrument separation. You should know that rotary devices, rotary instruments, they don't have any cutting tip. So hence, you need to provide a path for the rotary to glide through to the full working length. So we have a manual glide path instrument, or we can use a rotary glide path. You know, there are so many products available. So you can use a K file, very inexpensive. You have D finders, you have a pathfinders, you have C plus files, especially in the narrow canals, uh, C pilot files, great files. And of course, you know, once we have a hand instrument going to the full length, a full one length, as in like a working length, then we have rotary devices to enhance the. How about irrigants and lubricants? Here is a recommendation. Uh, this was the recommendation by Max Padden in his Mastering the Rotary Endodontics. He says up to 400% of resistance has been reduced the moment you use any of the lubricants, especially more so with the RC prep. So make sure that your chamber is completely filled with the irrigants. Never do the dry cutting, because the dry cutting immediately packs the fluids, and it leads to the cohesive bond between your instrument and the surrounding dentin, and leading to the lot of high resistance, and the blockage of the canal, and the dentin debris gets packed. So make sure that your chamber is completely filled with irrigants. Evaluate the canal. Before you decide what is the tip, taper, speed, torque, whether should you go for rotary or a reciprocation or adaptive, evaluate the canal, evaluate the curvature. There are so many methods of doing that one. CBCT helps you a lot in this regard. Whenever you have a complex cases, start making use of CBCTs in this regard. Low speeds are not recommended, and the high speeds, the instrument should be able to take up that one. So if you're working in a very, very complex canal, optimal speed with the less time in the canal is the best. Low torque may delay the process, but still your instrument separation chances will be less. Instrument motion, whenever you are in doubt, severely curved canal, go for a adaptive motion. And type of nickel titanium, I would strongly advise a heat treated or a twisted files for the curved canals. Tip and taper, when you have a severe curvature, stick to a lower tapers. Uh, Tip can be up to, depending on the apical gauging or a working width, but the taper should be smaller. When you have merging canals, always make sure that you prepare the straight canal first and then go for the merging canal. Try not to prepare the complex canals first. As a rule of thumb in endodontics, always prepare the simpler canal first and then go for the complex one, because the complex canal puts a lot of stress on the instrument and you don't want to use that stressed instrument on the simple canal. So the another guideline would be, whenever you are in doubt, what speeds to work with, your safest speed would be somewhere around 300 to 350. You can comfortably work with, unlike you are working with the XP shaper, which can go up to 800 to 3600 rotations according to some studies. Lower torque might reduce the might increase the working time, but still I would say you'll be on a safer side. Less chances of instrument separation. Excuse me. And try not to spend too much of a time within the canal. Once the instrument reaches the apex and once it takes a one single rotation, that means your canal is prepared. Try not to repeat that one by repeatedly picking the canal again and again. More time means more stress on the instrument. That is how the instrument takes. If I have to give you a little clinical idea, two best ways of breaking an instrument is, one is by forcing the instrument, and the second one is spending a lot of time with the rotary instrument in the canal. Some clinical tips, just as a take home message for you all. Excuse me. I see many people holding the handpiece in a very, very different way. I would strongly advise, uh, try not to keep your finger, once you turn on the motor, you're not going to switch it off, turn it off within the canal. So there's no point keeping this index finger there. So not advisable. Try not to put your index finger over the head, because you may apply up to the 2 kilos of load. And what is advisable is a passive pressure around 50 to 80 grams. So this is also not advisable. The best method to, of course, you cannot hold it here and try to prepare the canal. This is also not advisable. The best method is hold it like a pen. You'll have a better control. A small amplitude pecking can be done, and that helps you a lot on the clinical side. Hold it as closer to the head as possible in any given condition. Sometimes, yes, you are working on upper 7 or 8, you may not be able to hold it that close. That time you can move your fingers bit backward, but otherwise hold it as close to the tip as possible so that you have a complete control and you can deliver a small amplitudes of vertical strokes. 3 to 5 pecks, make it a rule. 3 to 5 pecks of the canal preparation, something like this. Instrument should be rotating as we go in. Light pecks. 3 to 5 pecks. Clean the instrument, irrigate the canal. So that's the best method of preventing the instruments, the separation. If you're using a reciprocative or adaptive instrument, just a second. Then don't do the picking motion. Say, for example, if there's a reciprocating instrument, just keep it, or else the reciprocating action and the adaptive motion will never set in. So you don't have to peck it. Only for a rotary devices we advise that pecking motion, otherwise it is not a good thing. Now, Rakshan, if you can put the second pole, what is the torque influence? This is just those who are still understanding the torque part, what is the influence of torque on the performance of the instrument? So here, when we use adaptive motion, there is no pecking. It's a direct preparation in the, or else it doesn't go to the. Yeah, when we use a high torque, we may have both enhanced performance, but at the cost of high potential for instrument separation. There's a question, somebody had asked, like, what happens when we put for a zero torque? This literally means that you're holding the instrument and you're not rotating at all. So torque means like it is the amount of pressure that needs to be applied. That cannot be a zero torque. Now, by buying the Endo-motor, should we buy the finger activated method, this type of Endo-motors, or should we buy the foot control? Here is a newer product where you have the Endo-motor with a Bluetooth connected a foot pedal, and also it is connected to your uh, apex locator, and quite affordable also. So I would always suggest anything with a foot control, because the newer techniques like a TCA, a tactile control activation, if you have to pre-curve the instrument, and specifically you have to go in a specific direction where you cannot afford to have a rotating instrument. You need to engage the instrument, go into the canal, and then activate it. For all that purpose, I would personally prefer going with the foot control, but try and avoid the one with the cable. And I heard many devices are now started providing a Bluetooth control foot pedal for this. Should we buy the apex locator integrated end motors, or should we buy the separate ones? Let's see the benefits and limitations of these techniques. With the Just a second. With the benefit side, we can say that we can continuously monitor the working length, less number of attachments, and no need of separately doing the procedures. Auto stop, auto start features are there. Uh, Easy to maintain type of a thing. I would say yes, it is good. The limitation side, auto start, auto stop is like I have been using it with the various Endo-motors, but none of them are predictable. Sometimes they work, sometimes they don't work. At this point, I have my own concerns. I don't really go by the auto start, auto stop experimenting on the patients. Tried on many cases, and it was so unpredictable. It is like I just couldn't depend on that one. Okay, it's a good feature to have if it comes with the package, but I don't preferably go for auto start, auto stop, which comes along with the integrated apex locator. Now the question is, should I buy Endo-motor with the apex locator, or should I buy Endo-motor and apex locator separate? I have a very pragmatic perspective for this. Here, if you're buying the first Endo-motor, I would strongly suggest buy a separate Endo-motor and the apex locator, because like sometimes you may have to do only working length for a patient, or you may have to do only a canal preparation. And if you have multiple chairs, the one person might do the apex locator working length, and the other person might do the endodontics cleaning and shaping. If they are together, probably uh, the one facility, one benefit of this endomotor. But if you're buying the second endomotor, I would strongly advise buy one with the apex locator integrated, because sometimes in a very complex cases in a upper and lower with a limited mouth opening, with a where the x-rays are not possible and continuously your patient cooperation is less, and you want to finish the case a little little faster manner. In such conditions, your apex locator with the integrated with the endomotor would be a blessing in disguise. I would advise, if you're buying the second motor, please uh, go with the endomotor with a apex locator. If it's a first one, I would suggest separate things are better. That is, separate endomotor, separate apex locator. Now, considering that we have this newer generation endomotors where all of them can be integrated either by Bluetooth or by a cable, and I'm not a personal advisor for. I'm not advisor for the integrated one as a first endomotor. Should we go for the cord one or a cordless? One with a cable, one cordless one. Cable one, what we have, see, any endomotor, easily you'll be using it for 5+ years. That is the pattern I have seen. I don't see people easily discarding this endomotor unless there is a some damage to it. So cable can be an issue, because sometimes it is intertwined, and the maintenance and the sterilization and all those things. Cordless is always more easy to manipulate, and we have a swivel head, one with a woodpecker and Xmart handpiece is what we get. You can rotate the head of the motor in whatever the direction you want, and you can continuously work. And some motors where we have to reattach, but you can still be rotated. It can be attached to the main motor. So my suggestion would be cordless is always better. Foot control would be a great benefit. So everything gets connected via Bluetooth. This is, I find it very interesting because you know you can go clockwise, anti-clockwise, and the various features. You can use it as an only apex locator, only endomotor. I'm just showing you the latest features. I'm not specific on the brands and all those things. Torque. Uh, So torque can, there's a question I saw, what is the ideal torque? I personally always work with a little lower torque, somewhere between the 1.2 to 1.8. 1.2 is where I start with, and there's a question about that. Preferably work with this is Dr. Raghu Ganesh. Ideally, lower torque is better. Do the small experiment. You keep the torque level to zero point 0.8 and try to work with that. If that becomes very difficult, go to 1, then 1.2, 1.3, and you have a basic inclination towards working with a very low torque. Then you will be surprised to see how less instruments are separated during the clinical. Of course, it takes an extra few minutes to prepare the canal, but that is the a little. Uh, but now again, we can do it with a higher success. Sorry, of course, for the better success. Keep in mind, it is not the uh, endomotor or equipment which does the job. It is the operator who does the uh, a better job. how much ever the expensive, costlier, or whatever the instrument you buy, end of the day, unless you are thorough with the techniques and clarity about like what to do, what not to do, uh, only device will not fetch you the success. Uh, Thank you. And this is a latest photo yesterday. When I slept, it was night 2 o'clock. I was making all these videos, and some of the videos didn't come out that well. And those who wants to reach out for me, this is my contact number, and please look out for my blog, wordofmouth.in. Uh, so I'll be posting the articles about what are the latest developments and what are the latest clinical changes one need to do it. Uh, I'll be happy to answer uh, if there are any queries. What irrigants to use while using XP shaper to remove the GP points? Don't use any irrigant because it needs to generate the heat, and preferably don't use it anything. If you use a lot of heat, sorry, if you use a lot of irrigants, you may not be able to generate the sufficient friction to soften it. Don't use it. Uh, Thank you all. Roxanne, are we fine? Okay, here is Dr. Abhijit Bagalkut asking a very interesting question. And like, should we go for an expensive one or should we go for a not so expensive one? Should we invest? And I always think it from this perspective. Like the you should have a investment towards the equipment which is a future proof. You don't want to change it every 2 years, 3 years. You buy something and in 3 years that is obsolete, don't go for it whenever you are in doubt. I follow a very simple thing. If I have to decide on a loop, I will preferably go for a not so expensive one first and use it and see how far I get accustomed to that, and then once I'm very very comfortable with it, then I would go for the best possible one. So that is my strategy. You may have your own philosophies for that, but it is always better to go by that. Uh, Adaptive motors use both rotary, adaptive, and reciprocation altogether. There are too many questions. How to change from one feature to another feature? You will have a setting button and any Endo-motor. How to go from rotary to reciprocation or adaptive. Latest I have seen, I need to bring this to your attention. Like some Endo-motors are saying that they have uh, adaptive motion, but the true adaptive motion has a two stages. One is like it has to go 600 degree and give a small pause, and when the when it meets a certain torque, it has to transform itself into 370 and 50. So just adaptive motion of 370 and 50 is not a true adaptive motion. Sorry. The blog is word of mouth. word. Sorry, that was my blog. Word of mouth dot in, because this is a key factor. Don't say it is a word of mouth. This is a word of mouth. Rahul, should we start the rotary in initial practice? I would say earlier is better, because once you get used to your hand instrument, it's very difficult to change it from one method to other. Advantage of reverse motion, I don't see any advantage of reverse motion at all. And reverse motion is only to disengage the dentin. Uh, no, Dr. Saharsh, don't switch off the auto reverse button. It should be there all the time. That is an indication, notice for you to make sure that like you are continuously uh, working on the sorry, you're continuously being informed about the torque required. Dr. Shreya, this is like ideal torque for and the speed for all the motors, all the instruments, almost. See, the torque is always in the operator's control. The speed is always worked out by companies to give a better performance. But when they give a better performance, they have not worked on each and every tooth. So it's operator responsibility. Uh, the company or the manufacturer is always worried about the performance of his file rather than what is your case. So hence, I would suggest the speed of somewhere between 350 and torque of around 1.2 to 1.8. You are on a safer side for most of the system, unless they insist on a higher speed. Dr. Karikalan, please do not use Gates glitter. Nowadays, we have a beautiful orifice openers. Now, if you're using a Gates glitter, I would advise the speed should be somewhere between 800 to 1000, and the torque should be at least like a 2.5 to 3, especially if you're using it for post space removal. ಎಲ್ಲಿದೆ? Hello, Roxanne. Hello. Okay. Are we done? Hello. Hello. Are we done? I'm done with the thing. Okay. Oh, wind up the thing. I'll. Okay. Thank you. Last three questions. You can please elaborate the different motions used in. I have used a rotary, reciprocating, and adaptive motions. Dr. Lopa. Thank you, everybody. It's been a pleasure sharing a little knowledge with you all. Uh, as you have seen, my contact number is 9448089542. I'll be happy to debate and discuss in case if you have noticed anything that which is not what you believe in. Uh, by sharing and discussing only we can enhance our knowledge. Thank you all. Stay safe. Stay at home. Uh, Things are getting better. Uh, India is doing really, really well compared to any other country. Uh, so I was in US last month, and it was pretty fine. And it's been a month. The things have really changed a lot. I feel blessed to be here. Thank you all. Thanks again.